In 2010, 89-year-old Kay Carter left Canada for Switzerland because the choice she wanted was illegal at home. Kay had spinal stenosis, a condition that progressively compresses the spinal cord. By mid-2009, she needed help with virtually all of her daily activities. Her mobility was extremely limited, and she lived with chronic pain. Her condition was devastating, but it was not fatal. Kay asked her daughter, Lee Carter, and her son-in-law, Hollis Johnson, to help her travel to Switzerland for an assisted death. They knew that helping her could expose them to prosecution in Canada. Still, they agreed to accompany her. After Kay died, her story became central to a legal challenge that reached the Supreme Court of Canada. In 2015, the court ruled that the blanket criminal prohibition on physician-assisted dying violated the rights of certain competent adults suffering from grievous and irremediable medical conditions. One woman, one family, and one journey abroad helped force an entire country to confront a question it could no longer avoid. Should assisted dying be available to people who are not terminally ill? Supporters may hear Kay Carter's story as an argument for compassion and personal autonomy. Opponents may hear a warning about medicine crossing a line it can never safely uncross. This question divides doctors, disability advocates, legal experts, religious communities, patients, and families. It is not a debate between people who care and people who do not. Both sides are trying to prevent suffering. They disagree about which danger is greater. I am Dr. Adrian Mercer. This is an educational discussion about medical ethics, law, and public policy. It is not personal medical advice, legal advice, or guidance for harming yourself. If this subject connects to something you are personally experiencing, please contact a qualified health professional, a crisis service, or emergency support in your area. We also need clear language. Assisted dying laws differ widely. Some places allow a clinician to prescribe medication that an eligible patient chooses to take. Some permit a clinician to administer the medication. Other places prohibit both. This video will discuss eligibility, safeguards, and ethics without describing methods. The traditional argument for assisted dying usually focuses on a person who is approaching death from advanced cancer or another terminal disease. The patient is already dying. The disputed question is whether the patient should control the timing and manner of an approaching death when suffering cannot be relieved acceptably. The controversy changes when death is not approaching. A person may have a severe neurological condition, chronic pain, a disabling illness, or several incurable conditions. They may experience suffering they consider intolerable, yet their natural death may not be expected for many years. If the law excludes them, supporters call that unequal and cruel. If the law includes them, opponents fear that medicine begins treating death as a solution to disability, social abandonment, or despair. Canada removed the requirement that a person's natural death must be reasonably foreseeable in 2021. The law created two tracks. Track 1 applies when natural death is reasonably foreseeable. Track 2 applies when it is not. Track 2 includes additional safeguards because the patient is not near death and the assessment is more complex. Under the Canadian framework, a person must be an adult with decision-making capacity. The request must be voluntary and informed. The person must have a serious and incurable illness, disease, or disability, an advanced state of irreversible decline, and enduring suffering that cannot be relieved under conditions the person considers acceptable. That does not mean anyone who is tired of life can receive assisted dying. It does not mean poverty or loneliness alone creates eligibility. It does not mean a patient has an automatic right to demand that any doctor participate. Canada also continues to exclude people whose sole underlying medical condition is mental illness until March 17, 2027. That delay reflects deep disagreement about whether clinicians can reliably determine that a psychiatric condition is irremediable, whether a wish to die can be separated from symptoms, and whether health systems are prepared to assess such requests consistently. In 2024, Canada reported 732 assisted deaths under Track 2, representing 4.4% of all assisted deaths that year. That is a small minority of Canadian cases, but it is not a theoretical category. Hundreds of people whose natural death was not reasonably foreseeable received medical assistance in dying. Track 2 requests are supposed to receive added scrutiny. The assessment process generally requires more time and relevant expertise. Clinicians must explore whether reasonable and available ways of relieving suffering have been seriously considered. The purpose is to prevent a permanent decision from being made, while a treatable problem, external pressure, or missing service is mistaken for an irremediable condition. Supporters see this structure as a careful middle path. They argue that the law does not erase the difference between terminal and non-terminal illness. It responds to that difference with stronger safeguards rather than an absolute prohibition. Opponents see a more fundamental problem. A longer assessment can improve a decision, but it cannot convert uncertainty into certainty. A doctor may document that known treatments have failed without knowing what treatment will exist next year. Two competent specialists may reach opposite conclusions about whether further improvement is reasonably possible. There is also a difference between refusing an available treatment and never having meaningful access to it. A person may decide that another therapy is unacceptable because of severe side effects or a low chance of success. Respect for autonomy means patients cannot be forced through every imaginable treatment before their suffering is taken seriously. But a person may also decline an option because transportation, cost, language, disability access, or months on a waiting list make the option practically impossible. Calling that a free refusal can hide a failure of the health system. The phrase, "under conditions the person considers acceptable," is therefore both compassionate and controversial. It respects the patient's values. It also means that two people with similar medical conditions might reach different eligibility outcomes because they judge the same proposed treatment differently. This is not unusual in medicine. Patients routinely make different choices about surgery, chemotherapy, and life support. The difference is that assisted dying ends the possibility of later reconsideration. That finality is why consistency, documentation, and independent review matter so much. Another concern is whether expansion changes medical culture. Patients usually enter a clinic expecting the team to preserve life, relieve suffering, and remain present when cure is impossible. Some clinicians fear that offering assisted dying outside the final stage of life may change what vulnerable patients believe doctors expect from them. Other clinicians argue the opposite. They say that listening to a sustained request does not devalue life. It can be part of taking suffering seriously, provided that the clinician is free to refuse participation and the patient is never steered toward death. Supporters begin with autonomy. Competent adults are generally allowed to refuse treatment even when refusal will shorten their lives. A patient may decline surgery, dialysis, ventilation, or artificial nutrition. If adults can reject life-preserving care, supporters ask why a person with incurable and intolerable suffering should lose all control simply because death is not close enough. They also challenge the idea that a terminal diagnosis creates a morally clean boundary. Prognosis is uncertain. Doctors can be wrong about whether a patient has 6 months, 12 months, or several years. Two people may experience equally severe suffering, but only one qualifies because one disease is expected to cause death sooner. Supporters see that as discrimination based on diagnosis rather than compassion based on suffering. There is also an equality argument involving physical disability. A person without a disability may legally refuse food, treatment, or life support. A person whose disability prevents them from acting independently may not have the same practical control. Supporters argue that an absolute prohibition can leave some competent adults trapped in suffering simply because their bodies limit what they can do without assistance. The Netherlands allows euthanasia in rare cases involving psychiatric disorders when strict due care criteria are met. Dutch law requires a voluntary and well-considered request, unbearable suffering with no prospect of improvement, full information, no reasonable alternative, consultation with an independent physician, and due medical care. A person who simply feels that life is complete does not qualify. Doctors are not required to participate. The Dutch Regional Euthanasia Review Committees reported 219 notifications in 2024 in which suffering was caused largely by one or more psychiatric disorders. The official report says particular caution is required and psychiatric expertise must be sought. Supporters point to these safeguards as evidence that eligibility beyond terminal illness does not have to mean open access. They argue that systems can require multiple independent assessments, specialist expertise, documented treatment history, careful evaluation of capacity, and confirmation that reasonable alternatives have been explored. Opponents answer that the most important judgments cannot be measured with a laboratory test. What exactly makes suffering unbearable? The patient must describe it, and the clinician must interpret it. What makes a condition irremediable? Some illnesses are unpredictable. A treatment that failed for most people may help one person later. New therapies appear. Personal circumstances change. A patient who sees no acceptable option today may feel differently after receiving housing, pain care, trauma treatment, assistive technology, or meaningful human support. Terminal cancer can also involve uncertainty, but the body is moving toward death in a way that places a natural limit on the decision. When the person is not terminally ill, the medical system is not shortening an unavoidable final stage. It is ending a life that might otherwise continue for years or decades. The most serious objection is that a request to die may reflect untreated pain, poverty, loneliness, inaccessible disability support, or inadequate mental health care. In theory, assisted dying is chosen only after alternatives are considered. In reality, alternatives are not equally available. A patient may be told that better home care exists, yet remain on a waiting list. A person may qualify for assisted dying while lacking affordable housing, specialist treatment, or sufficient daily support. This creates a disturbing inequality. Death may be administratively available before a decent life is practically available. Disability rights advocates often emphasize this point. Many disabled people experience others underestimating their quality of life. A newly disabled patient may hear predictions that life will be unbearable, only to later build relationships, independence, and meaning. If clinicians carry unconscious assumptions that disability is worse than death, an apparently neutral assessment may not be neutral at all. Supporters respond that denying every request because some disabled people face discrimination can also be paternalistic. A competent adult with years of lived experience may understand their condition better than observers who insist that life must remain acceptable. Protecting a group should not require silencing every individual within that group. This is why the debate is so difficult. The same policy can be described as protecting vulnerable people or controlling competent adults. The same safeguard can be described as careful review or an obstacle placed in front of someone who is suffering. Mental illness makes the conflict even sharper. A wish to die can be a symptom of depression, yet some psychiatric suffering persists despite years of treatment. Clinicians may disagree about whether any psychiatric condition can be declared truly irremediable. Hope is medically important, but hope cannot be verified like a blood result. Capacity is another challenge. A person can understand information and still make a decision shaped by hopelessness, coercion, fear of being a burden, or subtle pressure from relatives and institutions. The law may ask whether the request is voluntary, but pressure is not always spoken aloud. A safeguard written on paper is not the same as a safeguard available in real life. A rule requiring specialist review means little where specialists are scarce. A requirement to discuss alternatives means little when the alternatives have waiting lists measured in years. A promise of voluntary choice becomes fragile when the patient feels expensive, dependent, or unwanted. Oversight also matters. Reviews conducted only after a person has died cannot reverse a mistake. They can identify patterns and improve future practice, but the central decision is irreversible. On the other hand, prohibition also creates irreversible harm. A person may spend years in suffering that they consistently and competently reject. Families may watch someone deteriorate while the law offers no path that the patient considers humane. Refusing access is not a neutral action, simply because the state does nothing visible. The debate is not simply between compassion and cruelty. It is a conflict between two forms of protection. One protects competent adults from being forced to endure suffering they find intolerable. The other protects people from receiving death when what they needed was treatment, support, time, or a society less willing to view dependence as indignity. If assisted dying is available beyond terminal illness, the safeguards must be stronger than a checklist. The medical condition must be serious and incurable. The person must have stable decision-making capacity. The request must be persistent and free from pressure. Independent clinicians with relevant expertise must agree. Reasonable treatments, pain care, disability support, housing help, and mental health care must be genuinely offered, not merely mentioned. There should be enough time to evaluate whether the request changes as suffering is treated and circumstances improve. There should be transparent reporting, independent review, protection for clinicians who decline participation, and meaningful investigation when standards are not met. Even with those safeguards, honest people can conclude that the risk remains too high. No assessment can guarantee that a person would never have changed their mind. No law can remove every social pressure. No professional can predict every future treatment. My conclusion is cautious. Terminal illness should not be the only fact that matters. Some non-terminal conditions can produce profound, enduring, and medically documented suffering. It is possible to understand why a competent adult would demand control. But expanding eligibility changes the moral role of medicine. A health system must never make assisted dying easier to obtain than pain relief, disability support, psychiatric care, safe housing, or human companionship. Choice is not fully free when survival requires resources the person cannot access. Any jurisdiction considering expansion should prove that support is real before calling death a choice. The burden of proof should remain extremely high, especially when prognosis is uncertain, mental illness shapes the request, or social deprivation contributes to suffering. So what do you believe? Should assisted dying remain limited to people approaching death, or should competent adults with incurable and intolerable suffering qualify even when they might otherwise live for years? Please discuss the issue respectfully. Behind every argument is a real person, a frightened family, and a decision that cannot be undone. If this conversation helped you examine both sides, subscribe for more evidence-based discussions about the hardest questions in medicine.